Hello, my name is Alicia Delgado and I'm a student nurse practitioner. Today I will be doing a pulmonary and cardio assessment. I'm going to start off with doing a posterior pulmonary assessment. So the first thing I'm going to start with this assessment is inspection. Overall looking at my patient's back, and I'm looking for any obvious signs that would indicate something is not normal. So right now I'm looking at the color of his skin, and it's normal for his ethnicity. Feeling the temperature, and it's warm throughout. I'm feeling for texture, and it's nice and smooth. Moisture is dry throughout. I'm not feeling any areas that are, abnormally sweaty versus not. The skin turgor is nice. It retracts right back. There's no edema. I'm not seeing any bruises, scarring, lesions, or nodules. The next thing I'm going to inspect for is overall respiratory distress. I'm going to look for any signs and symptoms that would indicate that there's a breathing issue happening. So I'm going to be looking to see, is my patient using accessory muscles to work to breathe? Is he working hard to breathe? I'm not seeing any accessory muscles in use. From this side so far, I'm not seeing his sides, or there's no retraction happening. I'm not seeing, his ribs really working hard to help him breathe in and out. I'm not seeing, him hunched over in a tripod position. He doesn't look tachypnic to me. I'm not seeing any cyanosis. So far, he just looks resting and comfortable. I'm overall looking to see if there's any deformities happening. Am I seeing any bony protrusions? Structurally, is there anything that seems out of place? I'm not seeing that. Overall, he looks very symmetrical, so I have no concerns as my overall inspection. I'm looking at his respirations, his rate, rhythm, pattern, all seem normal to me. I'm not seeing, I'm not hearing any wheezes. I'm not seeing him really short of breath. Again, nice and relaxed. The depth, there's not a huge deep inhalation. Also not really shallow either. So depth looks normal to me. Overall excursion, movement up and down of the diaphragm is a nice, relaxed, normal rhythm. Next, I'm going to palpate, and I'm going to just touch you and I'm going to be palpating your shoulders, your scapula, and your spine. And I'm feeling for any tenderness. Are you tender in any of these areas?
No.
Okay, and I'm feeling for any bony protrusions. Is anything doesn't feel right, sticking out of place? Any, nodules, bulges that I can palpating? I'm not palpating any of that. Next thing I'm going to do is I'm going to palpate for symmetrical chest expansion. So I'm going to place my hands around the 10th, intercostal space, and I'm going to kind of pinch in a little bit, and I'm going to have you take a nice deep breath in and exhale. And again, I was looking to see is one hand moving up versus the other, and I didn't see that. It was nice and equal going in and out upon inspiration and expiration. Next, I'm going to palpate for tactile fremitus, and basically I'm going to use the palmar aspect of my hand, and I'm going to place this on areas of your back, and I'm going to have you say 99. And what I'm going to be looking for or feeling for are vibrations. And the most important aspect during this part of the assessment is to make sure that the vibrations feel equal on each side. So just repeat 99 when you feel my hand.
99, 99, 99, 99, 99, 99, 99, 99.
Perfect. Thank you so much. And the vibrations were equal in comparison from one side to the next. The next thing I'm going to start during this assessment is percussion. So I'm going to percuss from the apices, which are the tops of the lungs, all the way down, and I'm going to try and map out the lung tissue as I am listening for resonant sounds throughout. And while I'm doing this, I'm avoiding the bony structures, the scapula and the spine. Okay. And then I'm also, with using percussion, I'm going to identify the diaphragmatic excursion. And this is basically, I'm going to measure how much the diaphragm moves between inspiration and expiration. So I'm going to have you take a nice deep breath in, and when you're ready, hold it on the inhalation, and I'm going to do that same motion as you were feeling on your back before.
Okay.
Okay, you can relax. And I'm going to have you do the same exact thing. I'm going to do it to this side as well.
Okay.
Okay, thank you. You can relax. So it's even on each side. Now I'm going to have you do the same exact thing, except for in this case, I'm going to have you hold, after you exhale all the air, you're going to hold your breath. Okay?
Okay.
Okay, you can relax and breathe regular. So this is the space I got. So that is about 4 to 5 centimeters. I would measure exactly. Normal is between 3 and 6 centimeters, so he falls within that normal range. The next thing I'm going to do is I'm going to start my auscultation portion of the assessment, and I'm going to listen for breath sounds. So I'm going to do the posterior breath sounds, and then we'll move to the lateral after I do listen for some abnormal lung sounds. So first I'm just going to do normal auscultation of lung sounds posterior. When I place my stethoscope on, I'll just have you take deep breaths in and out for me, okay?
Understood.
And last one. Thank you. Okay, so I didn't hear any abnormal lung sounds. I didn't hear coarse crackles or fine crackles. I didn't hear any wheezing. Clear throughout. Nothing was diminished. So vesicular lung sounds throughout. The next thing I'm going to do is I'm going to assess for any consolidation or maybe an abnormal density throughout the lungs. So there's 3 different tests you can do when performing this or trying to assess for this. The first is called egophony, and that's where I'm going to have you make E sounds for me as I'm listening with my stethoscope. And what I'm listening for is a nasally A sound, and that would indicate to me that's an abnormal finding, is that there's some fluid or consolidation happening in the lungs. What you want to hear for a normal lung is an E throughout. So I'm gonna place my stethoscope and have you say E for me.
E, 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 E.
Thank you. The next one I'm going to do is bronchophony, and this is where I'm going to have you repeat the word 99 every time I place my stethoscope. And an abnormal finding would be if 99 sounded extremely loud and clear, almost as if he was saying it into my stethoscope, versus a normal finding, which would be distant, muffled. It's almost hard for me to identify him saying the word 99. Okay? When you're ready.
99, 99, 99, 99, 99, 99, 99, 99.
Thank you. And then the last one is going to be the whisper pectoraliquy. And so I'm going to, with the stethoscope, play or have him whisper 1, 2, 3. I apologize for that. So again, the whisper pectoraliquy test. So I'm gonna again listen for. I'm gonna ask that you whisper 1, 2, 3, and again, same as the one previous before. If it sounds really loud and clear to me, then this would indicate some consolidation happening. But again, so you wanted to hear almost distant muffled sound or not even hear it at all. So whisper 1, 2, 3. Okay, thank you. Okay, now I'm gonna, since we're here, I'm going to check for, this is not part of a lung assessment, but since we're in this position, I'm gonna show CVA tenderness, and this is a test for that can possibly indicate maybe a possible urinary tract infection or kidney infection. So the kidneys are located in the costal vertebral angle. So a way to identify that is you're going to look for the end of the rib cage on both sides, the 12th rib, and where the spine is, and there it creates this angle. And so part of your kidneys kind of sit here. So I'm going to palpate for that. So I'm going to place my hand, make a fist, and I'm going to hit my hand, and you let me know if you feel any tenderness, okay?
Okay. No tenderness. No tenderness.
Great. If there was an extreme amount of tenderness, maybe that would indicate there's something going on with the kidneys. So now we'll move on to doing the lateral lung sounds and the anterior. So I'm going to have you turn around for me. And I'm going to just inspecting again. I'm looking at color, which is normal for the ethnicity. I'm looking at for any bruises, lesions, nodules. Looking for any swelling. I'm feeling the temperature, and it's warm. Moisture, it's dry. Texture's nice and smooth. Also looking for any scars, and I'm not seeing any of that. Skin turns the same as it was on the back, retracts really quickly, bounces right back. I'm also again looking for signs of respiratory distress. There's no nasal flaring. He's nice and relaxed. The chest is expanding nice and symmetrical on both sides. Not seeing any deformities. Overall, everything looks normal. I'm going to, again, I'm not seeing any abdominal breathing, any accessory muscles that would indicate that there would be any signs of respiratory distress, no cyanosis, nothing like that at all. So again, overall inspection, symmetrical, everything looks normal from what I'm seeing. I'm going to start palpating the chest expansion just as I did in the back, but I'm going to do this at the sternal borders on each side. So I'm going to place my fingers here and just take a nice deep breath in and exhale. And again, I'm looking at my hands to see, are they rising and falling evenly? And they are. If it was abnormal, one side would go up or be significantly deviated from the other hand, and I did not see that. So nice and symmetrical. Now I'm going to palpate for tactile fremitus, and again, it's going to be similar to what I did on the back, but I'm just going to have you say 99, and it's going to be in a few areas.
Understood. 99, 99, 99, 99, 99, 99.
Thank you. And again, I'm feeling for that vibration, and the most important aspect of this part of the assessment is that it's even on both sides, and it was. So now I'm just going to auscultate for lung sounds anteriorly, and then I'll move to the lateral lung sounds. So I'm going to start up above the clavicle here. Breathe in out through your mouth. Okay, and if you just bring your arms up like this for me, these are the lateral lung sounds. And then the right middle lobe, which is best heard anteriorly. Okay, thank you. Between the fourth and sixth intercostal space. So now I'm going to move on to the cardiac assessment, and I'm going to identify the 5 points of the heart to listen to, or the valves, and I'm going to listen with my diaphragm and my bell of my stethoscope. So moving on to that. So the 5 areas that are important to listen to when you're doing a cardiac assessment is you have your aortic, which is at the second intercostal space. Pulmonic, same second intercostal space, but on the left side. Then we're going down to the third intercostal space on the Erb's point. Then moving to the tricuspid, which is at the fourth intercostal space, sternal border. And then finally the mitral, which is the midclavicular fifth intercostal space. So those are the areas I'm going to be listening for. The aortic and the pulmonic. S2 is going to sound louder because those are the valves that you're hearing closed the most. And then the same with S1 sounds are going to be heard louder because the tricuspid and the mitral valve. So that's kind of like your normal findings of what is going to sound louder when listening to S1 and S2 sounds. So I'm going to start with the diaphragm. And you can just breathe normal. So again, this was the aortic, this is the pulmonic. This is Erb's. Here's the tricuspid. And the mitral. Now I'm going to listen with the bell of my stethoscope. And using the bell in this case is going to help me identify murmurs better. So murmurs are is going to help me hear and identify better with that aspect of the stethoscope versus the diaphragm. And I didn't hear any murmurs. So now I'm going to move on and identify the PMI, the point of maximal impulse, and I'm going to palpate it as well. So the point of maximal impulse, or the PMI, is actually where the mitral valve is. So you're going to actually, it's midclavicular, fifth intercostal space. And what I'm palpating for is I'm looking to feel between a nickel and a quarter size part of the heart, feeling it a little bit as it's beating. And I do feel it. And it is between those sides, nothing, if I felt it more laterally or not in this place, then that could indicate that, that there's hypertrophy going on, that the heart is enlarged. If it was like extremely really harsh on my hand, that could indicate that the heart is working really hard. Maybe there's some hypertension going on. So those are the important aspects when assessing for PMI. So now I'm just gonna listen to the heart in general. And I'm just gonna put a timer on the phone. And listen for a full minute. Oh, didn't have it on the right one. Okay, so the apical pulse, I listened to it for a full minute. It was 71 beats per minute, regular rhythm. I also at the same time did listen to his respiratory rate, and that was at 14 breaths per minute. I like to listen for lung sounds when I'm listening for cardiac, so the patient's not as aware, and that also helps get a more accurate respiratory rate. Okay, so I'm going to have you lie down for me. Okay. So with my patient lying flat down, I'm going to be starting with inspection. I'm looking, getting at eye level with his chest, and I'm going to be looking for any lifts or heaves, which basically I'm assessing overall chest abnormal movements of his chest wall. So lifts would be outward movements of the sternal or parasternal area, which is right here. And then the heaves would be like an outward movements that's like prolonged. like for a prolonged duration. So that's kind of what I'm looking for. And I'm not seeing any abnormal chest wall movements. It looks normal with the heartbeat. I'm not seeing anything that would indicate that there's something abnormal going on with his heart. Next thing I'm going to do is I'm going to palpate on those 5 areas, and I'm basically going to feel for thrills, which would indicate a significant murmur. So the aortic, pulmonic, herbs, tricuspid, and mitral. So I'm going to place my hand on all those points. And I'm not feeling any thrill in any of those areas that would indicate a significant murmur. The next thing I'm going to do is I'm going to auscultate while he's lying down those 5 areas again with my stethoscope. So the aorta, second intercostal space, pulmonic, which is the left side, second intercostal space, herbs point, third intercostal space, tricuspid, fourth along the sternal border, and then the mitral midclavicular, fifth intercostal space. Okay, now I'm going to try and listen to see if I can identify potential aortic regurgitation or mitral stenosis. I think the easiest for just position wise is I'm going to ask that you lay on your left side, which would be the left lateral decubitus position. And with that, I'm going to use the bell of my stethoscope, and I'm going to put it over the apex of the heart. And I'm basically going to listen for like a low pitched sound, basically seeing if I hear a murmur. This brings the valve closer to my stethoscope, and that's why this position is best to identify this heart sound. And I don't hear any abnormal sounds. No murmurs were heard in this. So now I'm going to ask if you could sit up for me, and I'm going to have you lean a little bit forward. This position, again, it's going to bring a specific valve closer for me to my stethoscope. I'm actually going to use the diaphragm for this one. And I'm going to listen at herbs point. And what I'm going to have you do is I'm going to have you take a nice deep breath and then exhale completely and then hold your breath as I listen, okay?
Understood.
When you're ready. And I didn't hear anything that would indicate a murmur, so no aortic regurgitation was identified. The last thing I'm going to have you do is I'm actually going to have you lay back in the reclined aspect of this, and I'm going to kind of lean you back. I'm going to get you to a 30 to 45 degree angle. So have your head lean back a little bit for me. And then I'm going to have you kind of look towards this way, tilt your head a little bit. And Perfect. And I'm gonna bring the camera closer for this aspect of it. And so what I'm looking for is I'm trying to assess for jugular vein distension here. So I'm assessing this part of the neck, and I'm basically looking to see if the central venous pressure is a lot. And if I did, I would see this vein pop out, and I don't see it at all. It's nice and flat. So this would be indicative of heart failure. So I do not identify that. So that completes my cardio and pulmonary assessment, as well as a few other things that I involved in this assessment. And that's it. Thank you.